Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Welcome to Back in Action. Josh here with Dr. John Lavelle. Doctor,
Welcome. Man.
Thank you for being here on
Absolutely.
Episode, 7?
Yes.
Is that where we're at? Seventh episode.
been a long
Just
time.
you and I today.
I know, no Dusty. We're going to miss
Did you
him.
fire him already?
No, he's still around. We're allowing him to take a vacation.
Oh, that's
We'll see, though.
That's asking
We'll see how this goes. Is it
That's
going to be the
asking a lot.
highest rating one? Is it going to be
Yeah,
better?
that's right. That's
we'll
right.
see what the audience
We'll
thinks.
check the metrics, vote, comment, all the things and stuff. Today,
We'll
we're
miss you,
talking
Dusty.
today we're talking about recovery.
Yes.
Essentially, it dovetails off of our last episode. Episode 6, we were talking about what happens when my MRI actually does show up something inappropriate, something bad, some sort of damage.
Yeah.
How we progress through that. So if you've failed to listen to episode 6, if you've ever had any sort of image that came back that was scary, fantastic episode. And the basis of that was, and we're going to get into a lot more of that when we talk about how recovery actually works, but the main thing we talked about, I think that if there was a theme of that, it's that even if the MRI is bad, it is not only not a death sentence, but you may be more common than what you may think.
For sure. And a lot of what we talked in the last episode, the MRI is not going to show everything. And we'll talk about that today. But a lot of things with injuries, the MRIs are phenomenal. It shows you so much detail. It's such a fun image for me to look at and show patients, but it doesn't pick up everything. So when you have an injury, oftentimes you may see things on the MRI if it's or a CT scan or X-ray, if there's a fracture, if there's a tear in a muscle. But there's a lot of things you're not going to pick up. Maybe it's just a strain in the muscle or in the ligaments or just a soft tissue, the fascial strain. You're not going to necessarily see that on the MRI. Sometimes you can see some inflammation in there, which is a little white or fluid buildup if it's bad enough. But a lot of times even the MRI won't show a lot of the injuries that we see with back pain.
Okay.
Or anywhere in the body.
Okay. So would that be a call to getting more than just the one image, but then also a call to having more hands-on? You were always talking about hands-on.
It's diagnosis is hands-on.
Okay.
So when we have an injury, if you're not I just came from the clinic this morning, had a patient call in, hadn't seen since 2019. At that time, she had some back pain, did some rehab exercises, got a little better, did a steroid injection in her arthritic joints in the back, and has done great now for 6 years. She's kind of kept up with the exercises, but she calls now 6 years later and she says, I just want to come in for an injection. And she got mad at my staff for not just scheduling the injection. This is 6 years later. We just explained, I got to diagnose it. It could be something completely different. I'm not just going to stick needles in you, call you in a medication. The diagnosis is the piece that's so important. I would say that in the story, but the patient story and that diagnosis. If you're not putting your hands on patients, you're never going to get a full recovery because you're not going to get the diagnosis right.
Is there ever a time where in that same circumstance that I call you and it's 2 weeks later or it's 2 months later and you're like, okay, cool. Or is that always me hunting for something that might not really be the appropriate fix? Like, I don't want to say a quick fix necessarily because it may have worked before.
Don't get me wrong. There's instances where someone's had, often if it's chronic pain, a flare-up, you know what it is. I'm just saying 6 years later,
for sure.
you want to put your hands on something. But if it's 2 weeks later, and I want to talk to the patient, but there's telemed visits. You can get information by seeing the patient. You can see how they move. That's still diagnosing them, watching how they move on Zoom or on a telemed visit and hearing their story, how they're moving. You can get a good diagnosis that way too. It doesn't always have to be hands on the patient, but eyes on the patient.
So we're going to talk about that in future episodes, but telemed, you would have them move?
Oh yeah, it's so important to be able to see their quality of movement, what they can and can't do. Are they limited bending forward? Can they not lift things up? And when they're doing that, when they're hinging, are they more doing a squat? Or are they reaching overhead? Are they arching backwards to get their arms up? So what's going on?
You continue to surprise me with some of the stuff that you're talking about. That again, I'm not trying to talk about all other doctors everywhere. I'm not trying to just rain all the applause on you, but that seems very rare. And for most humans I work with, that is not a thing. Am I right with saying that?
Well, unfortunately, yes. I mean, there's still many phenomenal physicians that do all that we're speaking of, but we do lose that art of that diagnosis, hands-on, eyes-on patients, because that's the most important part. And that's what patients respond to. We're getting a little off topic with recovery, but I think it's all part of it. If you're not seeing that quality of movement, talking to the patient about how they're moving, and then if you can in person feel how they're moving, you're going to miss a lot, or you're not going to get to the root cause to be able to effectively help them recover more quickly.
Okay, so let's talk about recovery. So let's start out with the 3 phases of recovery that we have. The one that interests me the most, and we've talked about this off camera, is the remodeling phase. And I'll tell you just a quick background story on why that shocked me and what pushed me into this. I've been coaching for decades, and old man, and ran a certain path until I had my first surgery, which was a light patella-ish surgery, jumper's knee that we thought needed surgery back all the way 2008. I say all that just to say that my first comeback was, you'll be able to start squatting in about 6 months, is what I heard from the doctor. When I got up out of the bed, I felt like I could squat that day. And I remember, back in 2008, confronted with that 6 months, what are you talking about? You were insane. And then on my own, going away and trying to find more and more data based on injury. And again, this is back in 2008, before our Bayer study in 2012, before a lot of data. A lot of time back then, especially, it used to be, it hurts, stop doing it. And I knew it wasn't right. And that's what kind of drove me into what we do today, to being able to help athletes recover, so on and so forth. And I know we'll get to that, but tell me about how we go from injury to healing, first phase, second phase, third phase, whatever you see and what tends to happen. I know that's a broad question, but what do those phases look like? What am I in for? Because I thought when I got there, surgery meant I was better tomorrow. And it was more like, you'll be able to squat again in 6 months. Yeah. And I was shocked.
Were you able to squat sooner than 6 months?
In a lot of pain.
Yeah.
In a lot of pain.
Yeah,
and I forced it.
And that's a hard one.
It was.
But it does not, those time frames are just a generality. And I hate when it's put out there as this is fact. Like ACL tears, you're not going to play for a year. Well, we now see athletes can get back from an ACL tear a lot quicker than a year.
For sure.
But so when you have an initial injury, you jump to remodeling, which is phase 3, which is kind of that rehab, recovery, you're back to moving. The initial phase is that inflammatory phase. So we'll stick with spine because that's most of what we're talking about here with your back. You bend over, lift something heavy, you have we'll say a muscle tear or a muscle strain. Okay. You're going to have this inflammatory response. And that's that acute phase. You need that phase to bring in the inflammation. So we always say, you have inflammation in your back, let's give you a steroid, let's give you an anti-inflammatory. That's not the best step initially. That ibuprofen you jump to take that initial instance is then squashing that inflammatory phase, that inflammatory response. We need that. So that can last, that first phase, maybe 3 days, it happens immediately to up to a week or so. So I usually say if we know through looking at the patient, diagnosing the patient, this is more of a soft tissue injury, I advise no anti-inflammatory. So ibuprofen, Aleve, goodies powder, whatever it is.
So if I can handle it, if I can tolerate the pain.
Tylenol's the better answer. If you need something for pain.
Okay.
Nothing is the best. Ice, I usually will use. Now, what does ice do? That decreases, it closes down, constricts your blood vessels. So you are going to get some loss of blood flow. So decrease it some, but not as much as an ibuprofen.
If I can forego the ice.
That's better.
Better to forego the ice. So the ice is there to help numb it and take away the pain. Same thing with the Tylenol. But if I could go cold turkey,
that's better.
Okay.
So we want that acute inflammatory phase for those first few days, because what's that doing? It's bringing in white blood cells. Specifically within white blood cells, there's macrophages and neutrophils, and those are what starts to increase that inflammatory response, as well as cytokines start to come in. Our blood vessels expand, we get increased blood flow to the area. That's all setting the stage. So it's doing that base level groundwork to help then build upon that so we can get to that remodeling phase. So we need those first few days of inflammation. So whether it's your back or let's say it's your knee, that you twist your knee or have that ACL, let's not say it's a full tear, but a strain, MCL strain, a medial collateral ligament, your knee gets swollen. That's not bad. That's a normal response. Now, if it stays swollen for months, obviously that's bad. But those initial first few days, you need that inflammatory response, or you're not going to recover as fast.
So a lot of times that when we hear inflammation, we automatically jump to this is the worst thing in the world. That's what's killing me. In this instance, and just to make sure we're clear, a post-surgery inflammatory response is the same thing. I mean, surgery is just another 100%. Injury, right?
Yeah,
so like those trauma. Are both the same thing.
Yeah.
Okay.
So you want some of that initial inflammation in there to set that groundwork of healing. It's the body doing its work. We have an amazing, God-given ability in our body. He set us up really well for us to recover on our own.
Okay.
And that's part of that process, that inflammation. So that would be phase 1.
Okay.
That can last, I would say up to a week or so.
About a week.
Initially. Okay. And now this is rough estimates, but initially from the initial injury for the first 5-7 days.
Okay.
And then you're going to jump into that second stage, which is the proliferative stage.
Okay.
When we start to develop some of that recovery or healing starts to occur.
How do I feel?
Phase 2.
How do I feel in the second stage versus the first? Is there a change in my perception?
That's a great question, actually. So that at first, and most people that have experienced injuries know, you get this sharp, really acute pain, and that's where it can be described as 10 out of 10. This is pretty miserable.
And I'm terrified at this point.
100%.
Right when that happens.
Yeah.
Okay. Yeah.
So that's that initial response. As that inflammation occurs, and then by the end of the week starts to settle down, then it becomes more of a dull ache, typically.
Okay.
As you get into that proliferative phase. And so that's when you're getting angiogenesis, which is new blood flow coming in. You have that inflammation that was there. That may be some of those cytokines might be settling out. So the pain is not quite as sharp and stabbing. It's more of a kind of dull ache in general.
This is where I would have, let's go to the back.
Yeah.
The first, it spasmed on me. It prevented me from moving. I'm locked up. I can't do anything. Mm-hmm. After a few days, maybe 6 days, that starts to go away and I can move, but I'm apprehensive.
Correct.
Okay.
Yeah. Even in phase 1, you want to keep trying to move, but it's going to be, if feel like you're in 10 out of 10 pain, it's going to be hard, but it's still not bed rest. Now it's not pushing through miserable pain, but it's trying to move as you can.
Okay.
And then
it's also not trying to stretch. So I did have a previous range of motion. Right. I'm not going to try to force it to get back to where I was.
Correct. Let the body have a couple days to heal.
Okay.
It's like you after your knee surgery. Let the body do some of its groundwork.
Okay.
Don't rush it per se, but also don't completely give in.
Okay. Do what I can.
Right.
Don't do as much
it.
movement as I can, but don't try to regain right back to normal function.
Yeah, and in the back, if it's, we can get into different reasons for acute injury, but we'll stick with kind of that muscle strain. It may feel like you can't get out of bed. Well, just try to sit up on the edge of the bed. Try to move a little bit. Try to roll those first 1 to 2 days. So you're still moving. You're not just laying flat, taking ibuprofen, and completely succumbing to it.
Which is what most people tend to do.
100%. It's that first response. So then you get into phase 2, and that can be from a week to, on average, 6 weeks.
Okay.
So let's say a month. That's when we start to get that proliferation. And the proliferative phase, what does that mean? You're proliferating cells into that area to lay the groundwork for phase 3, which is the remodeling.
Staying on phase 2 really quickly, I know within the first one we're really trying to take, if we needed to take some sort of drug to help with that, okay, but generally speaking, we're not. What are we trying to do during that second phase to increase the speed at which I do heal?
So start moving. So you're going to start to do more of the stretching, move that body. I'll bounce this back to you, but if we had a patient that we had been seeing, they had that acute injury, what would you do? It's been a week, they saw me initially, or they went to an urgent care, they've kind of rested for a few days. What would you then kind of start doing with them from a training perspective?
We would first we'd first do an assessment. So I'd want to see where they're moving into. That could be a non-threatening state, meaning, let's take into example, I have them touch their toes. Okay, so cool, let's see, where can you normally get to? Just tell me. We don't have to run through all of that to put you in pain. But let's say we have half of our range of motion, and that's relatively comfortable. I would take what they're doing, obviously take the intensity of what they could do, take that way down, increase the frequency at which they did that movement that they could do in a non-threatening state. So let's say it's hinging. Okay, cool. Can we just do unweighted multiple times a day in a relatively pain-free state? It could still be uncomfortable. We can still have all of that, but do that often and keep putting that experience in and keep trying to talk to yourself like, I'm okay.
So you're not
I'm
pulling
okay.
that. They have pain. They strain their back. They have pain bending forward. You're not just going to put them in extension. You're going to actually have them start hinging.
Correct. If we can do that, I would also go to, maybe we can get to some ground-based activity, again, depending on what it might be. But can we have the thing move through some sort of range of motion? If we're talking about the back, can I go to extension with, again, not too much pain? I'm uncomfortable. I'm not really kicking it up to the next level, but I'm not doing anything. And then most importantly, when I stop doing the thing, it's totally fine to be sore. It's not okay to be worse off. So if we're using our system of 1 through 10, and you come in at a 5, and then you leave at an 8, and it stays at an 8, I've done a poor job. But if we're at a 5, we start moving around, it gets me to a 6, I stop doing the thing, and then I go back to a 5. You're proving to yourself that that's okay.
Right.
And then the nice thing about an assessment is that I can just take it again. So at the end of the session, what do you like? At the start of the next session, what are you doing? Can you go even further? And what you should see is there's just a little bit of progression each and every time. You may get to the same pain state, but your range of motion would increase. And if I've done my due diligence by pulling the intensity down, I've increased the frequency and decreased the volume, that should start to get the athlete to moving into situations much, much better. And there could be movements that I just execute. I could amputate the hinge for now.
Yeah.
And I'm going to introduce that later as I've made them more comfortable with other exercises. So if we're talking about the back, often is the case that, and I know you know, that if I hinge, then that's the thing that's going to spark a response, even if there's nothing going on there. So what if I did lunges? What if I did step-ups? What if I tried to load the glute tissue, the posterior chain, in a different way?
And you're still doing some hinging, doing all those things.
Oh, yeah,
but that's
100%.
What's groundbreaking. That's why you're going to recover quicker with the back if you start, and I use the word aggressive, but it doesn't mean aggressive you're doing 50-pound kettlebell swings.
Right.
You're just aggressively starting to move the body in the way it should.
That's right.
You're getting it back to that normal function.
And that's when you say kettlebell swing. So I would probably, again, amputate ballistic movement.
Right.
You can do 36-inch box jumps. Good for you. We're not doing them today.
Right.
Now, will we get back to that? For sure. Okay, let's say that, and this is what I see a lot, golfers, right? A golfer will come in. Do you want to be able to golf again? I mean, that's the conversation that I'm going to have. And of course, the answer is going to be, well, yeah, of course. Okay, well, we're going to get back to that. The point is not to take away things that you love. It's to give them back.
Yeah.
And the cleverest way to get there, and the fastest way possible, patience. You got to take a little time, but that's what we're going to go for.
Yeah, and you're slowly reintroducing that movement. Right. You didn't just stop it, rest for 6 months, and then go play golf.
That's right. Yeah, that's right.
It's slowly working their way back. And I see when you guys do that, oftentimes we'll keep with the golfer, they're better than they were before. And because now they're training and re-educating these muscles to move even more fluidly through that normal range of motion.
That's right. And a lot of golf, I mean, this seems pretty obvious, but a lot of golf is one-sided, and most athletes don't think through that. So if you're constantly going out in the same swing over and over again, and you never strength train, you're building up your own asymmetry. And the simplest thing is just to train in both dimensions, is frontal plane, sagittal plane, and actually working through those things.
Oh yeah, you see that not just golf, but pitchers. If they're right-handed, those right paraspinals will be just rock solid and twice the size of the left-sided paraspinals, because they're always using that lat on that right.
I love that you talk about how you look at the asymmetry of the muscle, because you even see that, and this is one of the things that you see off of a lot of throwers, and I wish Dusty was here to speak to this, because he's so good at this. But if you take your baseball player and you have a bench press and they're locked in, one shoulder is always so very different.
Yeah. And it can be dramatic sometimes.
But a simple fix is dumbbells. Is doing unilateral versus bilateral. And those are really simple fixes that we don't usually get to until it's a little too late.
100%.
Until we've been injured. And a lot of that comes from ego lifting, comes from old coaching styles.
Right. And it comes from just playing one sport all year round and then not doing the cross training.
That is correct. That's a whole other podcast.
It sure is.
That is a whole other podcast. Now,
it'll be coming.
If I'm in my proliferation phase, I'm already starting to move. Are there things that I can do outside of the gym?
Absolutely. So in that proliferation phase, as I said, you're going to get that term angiogenesis I used, continued increased blood flow, new blood flow to that area. And what's that bringing? We've had the inflammatory cells coming in. Now we're bringing in something called fibroblasts. And that's a different type of cell, but they help that area then bring in stem cells or different cells for whether it's myoblasts to build new muscle, lay down new muscle, or collagen to put down scar tissue or new ligament tissue.
Is this where I develop that inability to move if I'm not moving during this phase? Is this where that becomes scar tissue where I wasn't moving and becoming active, and then all of a sudden that shoulder range of motion that I did have becomes half?
Well, and that's this phase and the beginning of remodeling, because if you're not moving it, this new tissue is laying down, and how does it know where to lay down and striate those muscles or the ligaments or if you have more scar tissue coming in? Based on the stress you're putting it. So you want that stress to be that normal range of motion, whether it's in the ligament or the muscle or soft tissue. So it gets stressed along those normal, let's say, planes of movement.
So this is why that's a good idea that I'm constantly trying to regain range of motion as fast as possible. This is why when you're talking about an ACL, like the first thing we're trying to do, can we get to full flexion? Can we get to full extension? Can we get back to those movement standards?
That's why immediately after, like your knee or anyone's knee, or even if it's a knee replacement, you're replacing the hardware in the knee, but you still have all the tissue around it, muscles, ligaments, soft tissue, and you need to start day one moving that knee so you regain that full range of motion. You'll start building the strength later, you'll start getting those squats later, but initially you want those cells that are coming in to build up that muscle and those ligaments to lay down along the correct planes. And that's based on the stress you're putting into the body. So neurologically, the body knows where those cells should go.
Now I'm 6 weeks or so in, and I move to mostly remodeling. What starts to happen around this point in time?
So that's
how long does that last?
That's kind of what we just talked about. So that after that 1 month, 6 weeks, when you're getting that proliferative phase, then you get more into the more serious remodeling, where then you can get back to your full normal activity. But that can take, maybe another month, or it could take 3 or 4 months, depending on the tissue. Typically, if it's a disc herniation with disc injury, that takes a lot longer. Why does that take longer? Well, you have less blood flow to the disc. So sometimes the discs never fully heal. Most of the cases they don't. They still
Most
heal
of the cases
some.
They don't.
Yeah, because there's such less blood flow. And what affects that? You mentioned that in the proliferative phase. What can you do during those proliferative and remodeling phases to help this? A lot of it's nutrition, sleep are two other things besides the movement we discussed that will help get this going in the right direction. If you have comorbidities, heart disease, you're older in age, diabetes, those all affect
Define morbidity for me.
So just if you have something else going on with you systemically, like I said, heart disease.
If I have diabetes, if I have Alzheimer's or something like that.
How does diabetes affect it? Well, you get less blood flow. So every phase we've talked about is needing blood flow to that area to bring in, whether it's the inflammatory phase to bring in the inflammatory markers, or it's the proliferative phase to bring in those fibroblasts to help with this recovery.
Is this why different tissue heals at different rates?
Yes. So that's why discs, which have very little blood flow, or a meniscal injury. After about age 30, we have a lot less blood flow into our meniscus, so they often won't go in and repair the meniscus. Where if you're 18 playing football, you have a meniscal tear, they can go in and suture it up, and often it'll fully heal because you still have blood flow into the middle of the knee, into the middle of the meniscus.
This gets into successive rates of surgery, right? So like if it's a 50-50, is this called a sham surgery? Like it might be okay, it might not,
Basically.
Okay.
So if you and I tore our meniscus right now, they're just going to go out and if you needed to, remove that piece of meniscus. Okay. It's not just because it's easier, it's just not going to be successful. If you can go in and put sutures, it's going to re-tear.
Okay, got it. And that is because there's lack of blood flow.
Correct.
Okay, and that's because of age or because of inactivity or both? Mostly,
if just taking any comorbidity or any other thing out, it's age. You just get loss of that blood flow.
Okay.
That's why we'll switch to the back. In the back, if you get older and you have a flare-up of arthritic change or get a muscle strain, these phases we talk about will take a little bit longer because as you get older, you have less blood flow. But
so
if you have
anything to increase blood flow, maybe not anything is too strong of a statement, but if we can just, again, increase frequency of movement,
right,
then we increase blood flow and then we heal faster.
Absolutely. That's why that movement in the proliferative phase, that initial phase 2 and 3 is so important, because you're increasing blood flow. Why do you warm up before you work out? just to get that, we always say, get the blood pumping.
Yeah.
Well, it's truth, because if you want to bodybuild and get stronger, have hypertrophy is the muscle is you're tearing it when you're doing those bicep curls. That's why you build up the lactic acid. You're getting tears in there. And how does muscles hypertrophy? Is they lay down new muscle cells. Those blood flow comes in. You get new fibroblasts come in, the myoblasts start to lay down new muscle fibers, and you get bigger bicep.
And you look like you've done a couple bicep curls in your time.
That's
One or
not
two?
The goal isn't
Not
big
your thing.
biceps. It's to be able to be doing them when I'm 95.
Okay, that's just a side effect of being awesome is big biceps. Okay.
I like doing this podcast with you.
That's right. So now if we're in that remodeling phase, you said that will last, depending on the tissue. Am I looking to be out of that within a year? Within 6 months? I mean, maybe, and by of it, I mean, I'm doing all the things I want to do, but am I in a pain-free state?
Yes. If it's an acute injury and you're a healthy person, you want to be, depending on the tissue, it could be, like we said, a month or two, or it could be 6 months.
Okay.
If it's a disc that's herniated, causing pain down the leg, then you if it's a pinched nerve, what we call sciatic or radiculopathy, then that's a whole other type of tissue that has to heal the nerves, and those take the longest.
Okay, so why does the nerve take longer?
Because you have to regenerate the cells in the nerve. It's called axonal sprouting, or those axons, so you have a nerve and then this big tail off of it, which is the axon. And so the nerve is in the spinal cord, and then this big tail, let's say the low back, goes down the low back and then out down the leg. And so if you hit part of that tail and you get a little damage to the axon, which is that part that sends the motor function and pain down that leg, to repair that just takes time for the body to then, these other cells, Schwann cells, we get deep here, but they start laying down new myelin to repair that. So that can take 6 months or more.
Is this sort of like MS, like how we're having a problem with the nerve sheath kind of thing? Is that sort of, am I sort of on the right track with how to think of that?
With MS, those nerves are involved. It's a completely different.
Right, but in terms of like a nerve dysfunction, like that's sort of what we're looking for. Now, that being said, if I'm feeling pain in the nerve, am I sending a different signal than if I'm feeling sort of like a muscular pain? And what I mean is, should I change my thought process behind it? Is there damage happening, or is it the same thing where it's not really damage?
You want to talk to someone. So if you're hitting a nerve, you want to make sure, have you damaged the nerve enough where you have weakness, or if it's a part of that nerve or spinal cord is going to the bowel or bladder. Definitely. Are you having troubles there? Are you always can't control your bladder? Are you just urinating on yourself, or you can't move your leg because it's not just pain, it's actually you have foot drop and you got to go in and decompress around that nerve.
This is an inhibition at the muscle because of
a nerve injury.
Yes.
But usually that is not, like we've talked about, that's 1% or so of those cases when you have a nerve that's being injured, causing pain down the leg or down the arm. So most of the time, it's just more that phase 1 inflammatory response. Those inflammatory molecules irritating that nerve, and causing that nerve to fire abnormally.
Okay.
So since we jump to nerves, things that heal the quickest are muscles. Usually, will heal more rapidly than kind of ligaments, and then the disc.
Okay.
And if we're talking in terms of the back,
and tendon heal roughly the same.
Yeah, muscle still typically, like a muscle strain or pull will heal quicker than a ligament. Again, it's more blood flow into the muscle.
Got it. And
so
that's also because the
biggest,
muscle will stretch a little easier, whereas a tendon and a ligament don't really stretch. They're meant to be a little stiffer.
You want them to be, yeah.
Yeah, okay. What about bone?
So bone, again, bone heals better than a disc. So there's more blood flow into the bone.
Okay.
So that will heal. Let's say you have a compression fracture in one of the vertebrae. You were bending forward, picking something up. So your bone has this hard outer layer of the bone and an inner spongier layer of the bone. And so that inner layer can kind of sometimes get compressed down. Still, movement is the key. We don't jump to put them in a brace and limit movement. You still move as tolerated when we're talking about the spine here. Now it's different with long bones, but typically just in the spine, if you have that compression fracture, it's still that same continuum of those 3 phases. And just like we talked about, move as tolerated, then we're going to start moving you a little bit more.
Great.
As long as, again, you're not in that kind of 1% where the bone has burst and there's pieces hitting the nerve or anything like that.
So we want to continue movement as tolerated, like we said a few different times, but you're talking about if it's my arm, if it's my femur,
if you break your wrist or something like that, to get that to heal back together, we do immobilize it.
Okay, got it.
You typically, bone will heal. The average is about a month, 6 weeks.
Okay.
So we'll immobilize it. You still, every 2 weeks, typically will get x-rays, because if you're young, for my daughter, every summer now, 3 summers in a row, she's broken her wrist. Small little fractures. This last one though, we just immobilized it for 2 weeks, and she was out, and the next day she was doing, with Chastity, your wife, 30 pull-ups, so you heal it, you still, we have these baseline ideas, but you still want to track the patient.
So this is athlete to athlete, and this is also going to be age.
Yeah.
Yeah, so it's going to be age predominant, how quickly my healing is going to be. If I'm a little older, it's going to take a little longer, what my lifestyle looks like, my nutrition, my sleep, so on and so forth.
So that the age is a big piece to help with that blood flow, and nutrition sleep and nutrition are pretty good, but let's say you had to lose one of those where your lifestyle, you couldn't sleep, 7-8 hours. Nutrition is the next one to focus on after movement.
Are you telling me to do something specific, like what to eat, or are you saying more of just don't eat X?
Well, with the American diet, I always start with don't eat X. That's the easiest way to go.
What am I eliminating?
Get rid of things that are going to slow down that blood flow, slow down that process of healing. Okay. So a lot of inflammatory or processed foods.
Got it.
And I said we need inflammation. We don't need excess inflammation, or we don't need to put in molecules into our body or substances into our body that are going to make the rest of our body inflamed.
So it's fitness. Basically, we need enough stimulation to have an appropriate adaptation. We don't want to fall off the cliff. So if there's a food that I particularly respond poor to, and there's certain foods that we all tend to respond poorly to, and specifically, it looks like the amount.
Right.
So you're even saying that, would it be better for me, and maybe this is getting a little bit too much in the weeds, but would it be better for me to have a caloric surplus at that point in time where I'm trying to heal?
Yeah,
or would it be better to be in a caloric deficit?
A protein surplus. You want to get more protein. Yes, a caloric surplus, but that doesn't mean I want you to eat chocolate cake to beat more.
So what I recommend for athletes, just the easiest one that I've been doing for, again, like we said, decades, old guy doing fitness, 1 gram of protein per pound of body weight. That's a lot, but that tends to check all the boxes, and check all the boxes as you age. Mm-hmm. There's other studies that show that it could be kilograms per pound, or however you want to work through that, and every study shows something slightly different. But I've also seen the studies that tend to say that you really can't overeat on protein. Of course, you can overeat on everything if your calories at the end of the day are too many. Do you have a specific protein intake that you like?
Similar to what you said. I usually just say a pound of protein per kilogram body weight.
Got it.
Now that gets hard because not everyone knows how to do that conversion, but everyone can on their phone. Just because a pound per pound of protein per body weight just can get hard to reach sometimes.
Okay. Yeah, for sure.
Especially depending on the size of the patient.
For sure.
Where a pound per kilogram or 0.8 pounds per kilogram just makes it a little more easier. But that's kind of the minimal. If you're trying to hypertrophy or build muscle, I will say 1.2 pounds per kilogram or up to 1.5, 1.8.
So if we're talking about, like you said, like we don't want chocolate cake to be the thing kicking my calories up, but if I added to what I would normally do when I'm in my normative state, if I added 400 calories worth of protein on top of what I eat, that would probably be a good spot to be at. And then of course, making sure there's enough hydration to kick metabolic waste and so on and so forth.
Exactly.
Okay.
So that's the big piece with nutrition, is possibly increasing your protein up a little bit. Definitely staying hydrated is super important as well. And avoiding those, the easiest thing I tell people is just stay on the outside of the grocery store where it's whole natural food and drinks. You know, if you can raise it or grow it, that's what you want to put in your body.
Okay.
If it's made in a factory, leave it on the shelf.
Kick that, okay.
There's a reason it can last a year on the shelf.
Okay. Now talk to me about just some of the myths. I got a couple that I wrote down. I'm just going to rapid fire them at you. If it hurts, stop.
No? Okay,
tell me about that.
So if it's that 10 out of 10 pain, as we talked about at the beginning, back down a little bit, let that inflammatory process take hold, but then you want to slowly get moving again.
Okay.
And as we talked about, you don't want to overdo it, but movement is so powerful. you want to keep moving as best you can. As I said, even day one, if all you can do is roll over or sit up on the edge of the bed, start doing that. And this is true if you've had a heart attack or you've had a broken bone, you want to start moving.
Is healing a straight line?
Absolutely not.
How does it go?
And so that again brings that age factor in, but it depends what we're healing from. If you have age-related degeneration in your back, so disc degeneration, arthritis in your back, that arthritis is never going to quote unquote go away and heal. So arthritis is just the body breaking down over time. And so in arthritis, it's going to keep breaking down. So you may have in this kind of continuum of arthritis where your bones are starting to get more, your joints, I should say, are getting more arthritic, which is wearing away of the cartilage in between the bones, which make up the joint. As that cartilage is wearing away, that's going to keep happening. But let's say you have an acute inflammatory episode in that joint.
Yeah.
You can heal that, but you're still going to be breaking down around it. So you may still have some discomfort or peaks and valleys because of the underlying arthritis, but we can get you back to your baseline. Does that make some sense?
Yeah. How do you recommend, and we just talked about this at the beginning of the podcast with somebody, this was 6 years, maybe it's not the best example, but with somebody who comes to you and they start to heal and I'm a little better, then all of a sudden it feels like I've fallen off of that cliff. And being a coach and seeing this for decades, I know that is almost always the case. And I really prep my athletes to understand, like, hey, it's okay. Tomorrow when you get up, like everything's been good for 4 months, and then all of a sudden you're like, why is my knee swollen again? Like, that's okay and that's normal. How do you deal with that mindset of the athlete who, I think everything's great, and then all of a sudden
they have that setback, they fall down, and you're going to have those peaks and valleys. That's kind of the best way to talk about healing in general, because we're all going to age, so we're all going to have times where you're gonna fall in that valley. It's like the stock market. It'll keep going up. It'll keep getting better. But you're gonna have those times where you're gonna have those deficits.
Tell me if I'm wrong about how I pursue this with athletes. But the cost of being awesome may be that you get a little bit of a tweak and a pull. You can still go do all of the things that you want, but it's no less risky than sitting on the couch just hoping something doesn't happen.
That's going to be a lot more dangerous sitting on the couch, because you're going to more rapidly decline.
Okay.
So it's much riskier to do that. But what I do with patients when they have, like this one 6 years later calling me, I want to talk to them face to face, see what exactly is flared up, and then be able to encourage them why this is happening and how to move forward appropriately, not just rely on an injection. Because like I said, I don't want to do an injection today if it's an acute injury, because that's putting steroid, which is like the ibuprofen, to decrease that inflammation. Maybe we need a little bit of that inflammation in there right now, depending on what's going on with that patient.
More rest equals faster healing.
I think we've said no.
No? Okay. So I need, again, the appropriate stimulus with resting.
Especially if rest is sleep, you need to get that rest at night, or whenever, depending on your shifts, whenever you can sleep. But it's not just rest. I would say more movement is what's the key.
Do you find that athletes or patients who do get more sleep do recover faster? Do you find that there is a big sort of drop off to that? Like if I told you that I sleep 5 hours and you're like, ooh, you're going to increase that healing time. Can you point to that or
no? No, not necessarily. It depends on what your lifestyle has always been.
Okay, got it.
5 hours may work for you.
Okay.
But if you're someone that normally gets 8 hours of sleep every night, and now you have an injury and you can't sleep because of the pain, you're only getting 4 or 5 hours of sleep, that's going to limit your healing.
And that also goes to maybe the sleep thing happened before. All of a sudden life was 8 hours, right, and then I started sleeping 5, and that's then a month later I'm injured.
Your work changed, you're stressed, you can't sleep at night, you got a million things going on, your mind's racing. That's going to set you up for that injury for sure.
What about this one? And this one's the one I think that terrifies myself and others. I'll never be the same again.
We're going to make you better.
Okay.
And that's, we've talked about this.
Do I have to be the same? I think is an interesting question. Couldn't I even be better after the injury?
I joke, you could be better, you may be worse. There's a chance that depending on the injury, if it's you have now, the arthritis got so bad you had to have a knee replacement, you may never have you're not going to have the same movement in that knee. We may be able to get 90% there, but it may not be completely the same. So it may be changed, but what I focus on is what's your functioning after these injuries. I want to get you to your goal of whatever that is. And that's almost always
And
achievable.
that's that back and forth that we talk about. What is it that you really want to be able to do? That's what we're going to aim towards.
Right.
But the point of it is that you don't just sit around waiting for that to happen. You actively take the approach to make it happen.
Yeah, if you're an athlete and you're in the pros and you get a large disc herniation or some Tiger Woods, you may never be the exact same if you have severe traumatic injury to your leg and ankle, but he can still play golf. Maybe not to the same amount and level he did before, but Tiger Woods still could kick my butt on the golf course. So it's just maybe modifying those goals, but still getting you able to do the things you enjoy.
Okay. Our par 3 or par 5? What are you better at? You got your long game or you got your short game?
I got no game,
Oh.
but par 5, because then I
Par
got a
5.
chance to screw up and make up for it.
What's your best club?
Good question. Probably the 5-iron. I think that's 5
you
or
hit
7.
a 5? Well, really?
Yeah.
I can see a 7. 5, I think, is hard.
A little more forgiving. 5 is hard. Driver, if it's on, I have pretty decent distance, but
Straight?
that's the problem.
Okay.
That's why I said when it's on.
Okay, got it. So let's review. So when I first have the insult, the injury, or the surgery, there's about 6 days where that thing's going to be inflamed. I'm going to try to avoid medication. I'm going to try to avoid ice for the most part. There are times where if I can't handle it, that's fine. I'm expected to be in that with probably limited range for about 6 days a week or whatever.
Yeah.
And then I'm going to have roughly 2 weeks that's going to build on top of that, another week or another 2 weeks on top of that, the proliferation phase, where I'm going to try to keep aggressively moving, just meaning a little bit more with progress in maybe a painful state.
And that's the key, though, is progress. So a lot of times people will, in this phase, go to a clinician, physical therapy, chiropractor, and they'll give them a handout of exercises. That's not progress because you're just doing the same exercise over and over. Yeah, it might be a little better than nothing, but as you mentioned earlier, that you'll reassess the end of the visit and the beginning of the next visit, and you're going to add on to it. And that's the key, is giving some variety, but also building upon those wins.
Yeah. And we're gonna, and speaking to that, we're gonna race to load the athlete. I mean, you're always in a lot of athletes that'll hear that the first time in, they'll be timid of that. Some of them have never been loaded before, and you're always racing to load that athlete in the appropriate measure, appropriate volume, appropriate intensity, so that they adapt to it and come back bigger, faster, stronger, whatever you want to call it the next time. But it equates to progress in the long run, and you're trying to do that again. Pain is going to be there, and that 3 weeks post injury. And then I get into my remodeling phase that starts to happen around 4 to 6 weeks after the injury. And that's where I can really start to become who I was or get even better than before.
Yeah, at the end of that remodeling phase, let's say it took 4 months to get to the end of that, you may be 80% better.
Got it.
That also doesn't mean that's the end. They're still then getting back, the end of that remodeling, you're 80% better, but you want to start instituting all your normal stuff you had done before the injury. And that hopefully will get you as close to 100% as we can.
Okay.
But it's still a continuum of time.
Okay. And during that time, what almost always is the case is that I will perceive some sort of flare up, for lack of a better term, as a setback, when that really, truly is just the path of healing.
It is. You're going to you may overdo it. You may, let's say you've ended that remodeling phase. Now you're 8 months out. You're back to doing your normal stuff, but you do some back squats and you have a little twinge in your back. Often it'll only last a couple days. Mm-hmm. So back off that a little bit. Still, again, doesn't mean bed rest, but maybe don't go into the gym for a day or two, or see if they're working with you, see you that next day and do some more simpler movements to get you right back on that path going forward.
And that's the time where I'm sensitized.
Correct.
Like I've already had something, and maybe it's the movement pattern that becomes familiar. So if it happened when I was hinging, it's not because there's damage, like we've talked about a lot. That damage has essentially gone away or healed. Now it's the movement that excites the central nervous system, then oversensitizes to me on the actual movement pattern.
Perfection.
Okay.
You got it.
Okay. I'd like to talk next time about arthritis, if that's okay with you.
Yeah, I think that'll be a good way to bridge what we talked about here, but more specifically, how you can recover. Because that's, as I said, arthritis can be a little hairier because you have those peaks and valleys because you're always breaking down, but we're also trying to build up around it.
All right. Well, you heard the man. Join us next time and we'll talk about arthritis.
Nice one.
Thank you, sir. Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.